So it is my pleasure to welcome Dr. Samar, who's going to be presenting a brand new topic for us, AI applications in cardiac imaging. So I know we have a lot of ground to cover, and this is something that we have not discussed in our AI literacy courses previously. So without any further delay, I'm very excited to pass it over to you.
Good afternoon, everyone. Thank you so much, Dr. Perchik, for inviting me to this lecture series. You're doing some really important work here with your radiology residents, and I hope I can do something similar with our cardiology fellows in the future. So thank you for this opportunity. So I'm not a radiologist, I'm a cardiologist, and I'm the director of cardiac imaging at the Loma Linda VA Medical Center here in Southern California. And I'm not an AI researcher. I'd like to think of myself as an AI end user. So you'll see that my lecture is going to be very practical about what are the AI applications that we are currently using and how are we using them. So I have no disclosures. And our outline today we'll basically be going through some AI applications in echocardiography, cardiac MRI, and cardiac CT that are in use currently, commercially available to use today. And then we'll also try to cover some of the promising uses of these in the future. So if we look at the current AI landscape, radiology is clearly head and shoulders above all other specialties when it comes to the number of FDA-cleared AI algorithms. Cardiology stands at 154 algorithms when you include the cardiac-specific AI that is still listed under radiology. If we look at this breakdown of the cardiac algorithms that are approved, we see that most of them are ones that perform cardiac measurements, followed by flow, plaque analysis, calcium scoring, and we'll try to touch upon each of these in today's talk. So there are AI applications that are available for all parts of the cardiovascular imaging value chain, starting from patient selection all the way to prognostication and management. But as you saw on that previous slide, most of the applications that we're currently using are all related to cardiac measurements largely. And those predominantly come under the ability of these AI algorithms to perform segmentation and quantification. So we'll talk, when we talk about using AI for quantitative analysis of our cardiac imaging, there is a really good clinical rationale for doing this because all our imaging modalities involve segmentation of various structures in the heart, whether it's the ventricles, the atria, the valves, and so on. And doing these measurements manually is very time consuming. And whenever measurements are done manually, there's always operator dependence and more variability. So a really good clinical rationale in trying to automate these measurements, whether it is in echocardiography or in cardiac MRI. Now, we'll talk about echo first, and I know this is not the audience that is very interested in echo, but the reason for doing that is twofold. One is echo is our workhorse in cardiac imaging. It really is the first imaging test that almost any patient gets for whatever the indication be. And secondly, when it comes to the approved AI algorithms, CT and echo have the most number. So we'll talk a little bit about the important echo applications. Now, when these AI algorithms get approved by the FDA, they don't really have to be studied in a randomized controlled trial. And that's the reason why this paper got a lot of attention, because they actually tested an AI algorithm that would quantitate LVEF assessment on echocardiograms in a randomized fashion. And what they did is, after patients got their scans done by a fully trained sonographer, they then randomized them to have this LVEF assessment done either entirely by an artificial intelligence software or manually by a sonographer, and then presented these scans in a blinded fashion to a cardiologist to overread them. And what they found is that the cardiologists made important changes in the LVEF more frequently when they were presented with the echocardiograms that were manually measured by the sonographers than the ones that were done by the AI. And there were also definitely a time saving for the sonographer if they don't have to do manual measurements, but also a time saving for the cardiologist when they just had to tweak the images that were done by the AI, much less than they had to do with the images that were done by a sonographer. Now, we don't have only LVEF and echo measurements. There can be up to 60 measurements that are done in a normal echocardiogram. And there have been studies looking at several of these measurements, and several of these measurements are now well validated and are offered as part of packages in most of the commonly used vendors of echo machines. Now, this was a study that looked at a fully automated AI algorithm that did 60 measurements completely in an automated fashion. And then based on those measurements, generated a templated report. And they found that when this was done, there was almost a 70% reduction in the time spent for measurements and report generation. But keep in mind that this was significant only when the image quality was good and when the report was not a complex report. When it was a simple, straightforward echo report, this efficiency really played a big piece. But when the image quality was poor, the report was very complex, not much was to be gained with the use of the algorithm. We do have algorithms for disease diagnosis and echocardiography as well. And this is one that is commercially available to diagnose heart failure with preserved ejection fraction based on a single echo video clip. So it's not an entire echocardiogram. It's one 4-chamber video clip, which serves as the input for this convoluted neural network. And the outcome is a binary prediction of does this image represent heart failure with preserved EF or does it not? And when they compared the output of this model to our commonly used risk prediction models that we use for diagnosing patients with heart failure preserved EF, the performance of the algorithm was very good with the AUROCs consistently over 0.9. And this prediction also had prognostic significance because the patients that were classified as having heart failure preserved EF had lower survival compared to those that were classified as not having heart failure preserved EF. In a separate study using the same algorithm, they found that this was also predictive of heart failure hospitalizations, where patients with diagnosed heart failure preserved EF per the model classification had more heart failure hospitalizations. And this model is an example of explainable AI because they also provided these GrandCam images, which are graduated weighted class activation maps. And on these maps, these red areas tell us what are the areas that are most important for the algorithm and its decision-making process. And we can very clearly see here in this patients that has been correctly classified as heart failure preserved EF, we see that the algorithm is looking at mitral inflow, it's looking at mitral annular velocities, it's looking at tricuspid flow and pulmonary vein flow, which are all important parameters that go into making the diagnosis of diastolic dysfunction. Whereas in a patient who was incorrectly classified, the maximum weight lies in something that's probably outside the heart. Even more interesting than disease diagnosis is the ability to use AI to actually guide novice users who have no experience in obtaining echocardiographic images to be able to get some basic screening images via POCUS exam. And this was one of the initial studies that came out, and there have been other studies after this that tested this algorithm. And what they did is that they got millions of images of manipulations done by the sonographers and the corresponding images on their machines, and gave these images to expert sonographers and expert cardiologists and asked them to grade the quality of the images and to also give some recommendations of what could be done in terms of manipulations of the probe to improve the image quality. And they used that as the input for their AI model. And the output for the model is that the model gives sort of step-by-step instructions to the user as to what probe manipulations need to be done to get a good quality image. And in this study, they had 8 nurses, so not sonographers, not even sonography students, not medical residents, these were just nurses, who had no background experience and did a couple of days of training and then did about 30 echocardiograms. And when these echocardiograms were then presented in a blinded fashion to cardiologists to determine if these scans were of sufficient quality, well over 90% of these images were diagnostic for left ventricular size, function, right ventricular size, and pericardial effusion assessment. So this, again, are pictures from that same article where you can see this is how it works. Once the human places a probe on the chest, the algorithm can determine what is the target image and then starts giving them step-by-step instructions on what to do. And when an adequate image is obtained, it automatically goes ahead and grabs a cine clip, records a cine clip, and then moves on to give further instructions about the next image that needs to be obtained. And since we now have AI algorithms that do automated EF calculations, these POCUS probes are also embedded with those algorithms. So with these very basic images that are obtained by a novice user, the images can be obtained and basic calculations like an ejection fraction can be easily done. Moving on to CMR, just like in echocardiography, we have several manual measurements that are made in cardiac MRI that require contouring of the endocardium, the epicardium, and even contouring of the right ventricle to obtain all the volumetrics that are needed for a full CMR evaluation. And this is obviously very time-consuming again and causes a lot of inter-reader variability. We now have several approved AI models that will automate the segmentation process, making it easier, faster, and much more accurate. These are actually graphs from not a clinical study, but a competition that was held by Kaggle back in 2016, where they provided 1,000 MRI scans to AI developers and invited them to develop an automated software to assess LVEF. And you can see in that competition, these are graphs of the winning model. There was very good correlation with manually done volumes and left ventricular ejection fractions. So we do have clinical studies that have looked at how these models perform. And in this study, after the volumetrics were done by the automated software, an expert user was then allowed to correct them. And as you can see, there were differences. They were small, but there were significant differences in the user, in the expert corrected numbers compared to the automatically generated numbers by the software. But more importantly was the fact that there was a significant time saving for the expert to just correct the automatic measurements versus do a full manual EF or manual calculation of all these parameters. And another study went on to more or less determine the same thing. This was a different algorithm, but trying to do the same thing is automate MR measurements. And they again found the same thing, that using this combined method where the AI algorithm, the output of the AI algorithm is then tweaked by the final reader, results not just in better correlation of the volumes and ejection fraction, but also results in significant saving of time, anywhere from 3 to 4 minutes versus 12 minutes to be done fully manually. And this is the software that we use in our lab currently. And as soon as these images get loaded into the software, it will segment the endocardium, the epicardium, the right ventricle, both in systole and diastole, and provide all the necessary volumetrics. And this is done not just for the left and right ventricle. We do this even for the atria to get automated left atrial and right atrial volumes and strain. And again, all of these contours can be very easily manipulated if they are not accurate. This fully automated software will also segment the flow velocity images to automatically segment the aorta and the PA to perform a QPQS. And then it also will segment the left ventricle to perform automated T1 and T2 mapping. which makes it much more easier to get a global T1 and T2 map rather than manually segmenting these slices. Another interesting development that is clinically in use is an AI algorithm that sort of self-drives the CMR scan. Now, as all of you know, these CMR scans take very long. They go anywhere from 45 minutes to an hour. And the MR technologists do need to be trained to specifically perform these CMR scans. And that's one of the reasons why CMR is not in every community hospital and is still localized to larger academic centers, partially is because of the need for this additional training for the technologists. And this self-driving scan will automatically do the slice alignment for the technologist, so they don't have to manually plan all the cardiac views. It will automatically do the slice alignment for them. In addition, it will monitor for artifacts and will also do an automated cardiac shim to improve the image quality. And this was a study that came out of Brigham and Women's after they used this for about 6 months in their lab. This software is available on a couple of MR scanners. And when they did this for the first 6 months, they saw that their scan times for the CMR exams went down by about 30%. So it's not like they obviated the need to have a technologist do the scan. Of course, they needed the technologist, but the amount of time spent by the technologist was reduced. And there wasn't so much variability in their scans done by a super trained technologist versus a technologist that was, not as well versed in CMR scans. So much more consistency in the time required for the scan and even in the quality of the images by using this sort of self-driving software. Moving on to cardiac CT, because of the ability of these AI algorithms to segment the coronaries and then to even be able to segment the calcified plaques within the coronaries, we now have several deep learning algorithms that will automatically segment and obtain coronary artery calcium scores on these gated scans with very good correlation with manually done scans and a much lower analysis time. More exciting than just being able to automate the calcium score in a gated scan is the ability to use AI algorithms that can give a calcium score not just on a gated cardiac CT, but on a chest CT that is done for any other reason. And this really grabbed a lot of attention because of the need for patients to get lung cancer screening scans on a yearly basis, and the ability of these algorithms to be able to diagnose coronary calcium and essentially diagnose coronary disease in an opportunistic fashion for these patients who are not being referred for coronary disease evaluation, but being referred for lung cancer evaluation. And although these initial AI algorithms worked mainly on these lung cancer screening scans, there are now algorithms available that can obtain a calcium score on a CT scan that is done for a variety of different reasons. Even an attenuation correction CT scan that's done for PET imaging, or a chest CT scan that's done for radiation therapy planning can generate a calcium score for these patients. So it really widens the net of the number of patients that you can screen for coronary disease. And these algorithms had very good performance compared to when you compare these calcium scores in a matched fashion with the patients that had gated calcium scores done. This is the output of one of the commercially available algorithms. And what you will see is most of them will give a range. So they will have a range of 0 to 100, 100 to 400, and then greater than 400. And these cutoffs are based on guidelines that recommend these cutoffs for statin initiation therapy and for acceleration of statin therapy. So that's usually what the outputs of these algorithms will have. This is actually a study done by our VA colleagues at the Long Beach VA and recently came out, I want to say a week or two ago, where they developed a deep learning algorithm to predict calcium scores on non-gated CT scans. And they showed good accuracy with their algorithm. And more importantly, they also saw that this calcium score that was generated by this automated algorithm had prognostic value, and patients with the higher calcium scores had worse survival and a higher event rate compared to those that had lower calcium scores as generated by this automated algorithm. So we know that we can do this, we can get these calcium scores, and yes, they have prognostic value, but do they lead to any improved outcomes? And this was a study that came out of Stanford, where after they obtained these opportunistic calcium scores, they randomized these patients into a strict notification arm and a usual care arm. And in the strict notification arm, they sent off an email to their primary care physicians with the results of the calcium score and with what guideline recommended therapy would be for these patients. And 2 weeks later, the patients were given the same results as well. In this notification arm. And when this was done, they found that the statin prescription rate increased significantly in these patients. So more patients received guideline-directed therapy when these automated calcium score results were conveyed to their physicians and to the patients. To be borne in mind is the fact that, yes, it did increase statin prescription rates, but it also increased the rate of coronary artery testing in this notification arm. So that's something that really needs to be kept in mind when these algorithms are put in clinical use, to develop safeguards to minimize this unnecessary testing and unnecessary referral just for an abnormal calcium score when a patient does not have any symptoms. Moving on to coronary CTA. Coronary CTA now has a class 1 indication for evaluation of chest pain in patients with stable coronary disease. And although stenosis severity is the most important feature in these coronary CTs, the CADRATS 2.0 now recommends plaque evaluation in all coronary CTs. And plaque evaluation currently is not done quantitatively. We do this plaque evaluation qualitatively. Yes, we use the calcium score, but we also use a visual estimation of how many coronary segments have calcified plaque versus non-calcified plaque. And visual estimation, especially of non-calcified plaque, has a lot of inter-observer variability. At this time, we have several AI-driven applications that not only segment the coronary arteries, label them, they can differentiate the lumen from the wall. And because they can differentiate the lumen from the wall, they are able to quantify the amount of plaque inside the vessel wall and are able to characterize it. What is calcified, what is not calcified, what is high-risk plaque. And because they're able to do all of this, they can also determine stenosis severity. So when these deep learning algorithms were tested against expert readers, they found very good sensitivity and specificity. And they've also been tested against coronary angiography, which is the gold standard for stenosis severity determination. And they found good sensitivity and reasonable specificity. But more importantly than that is that these algorithms can do plaque quantification, which really is almost impossible to do manually. It's very time consuming. So it's not done in a clinical setting. It's only done in research settings where quantification of plaque for the entire coronary tree can be done. But now with these deep learning algorithms, we can do them in a clinical setting because they're done in such a short amount of time. And these deep learning-based plaque quantification software have been studied against expert plaque quantification, also against IVUS plaque quantification. And IVUS currently is the preferred test for plaque quantification in the coronaries. And these deep learning-based plaque quantification metrics, again, did show evidence of having prognostic value with a higher incidence of poor outcomes in patients that had higher plaque volumes. So because these plaques, the presence of plaque can now be quantified by these deep learning methods, a plaque staging system has been suggested, a quantified plaque staging system has been suggested using these cutoffs of 250 cubic millimeters and 750 cubic millimeters to separate patients into no, mild, moderate, and severe levels of plaque. And when this staging system has been studied, they have found that it does have prognostic value with patients in the stage 3 category having severe plaque clearly have worse outcomes compared to those that are stage 1 and 2. And this prognostication had a better performance compared to just clinical risk, using clinical risk and using a CAC-based system for prognostication. Another exciting development has been the ability to do CT-FFR. Now, FFR is an invasive metric, and it's the gold standard for determining if a coronary stenosis is really functionally significant. And this is done in the cath lab with a pressure wire across the lesion to measure the coronary pressure proximal and distal to the stenosis. And an FFR value invasively in the cath lab of less than 0.8 has been shown to be a metric for functionally significant stenosis. For about the last 10 years or so, we've been able to get these FFR values through CT angiography. But what this involves is the development of a very complex 3D fluid dynamic based model, FFR model from the CT images. It has very good accuracy, but it's very computationally heavy. It is not something that can be done on site in any given imaging center. The CT images have to be sent out to a vendor, and then this quantification is done, this FFR values are generated, and then these images are sent back, and this takes about a couple of hours. So there has been a lot of interest now in looking at these deep learning based models to generate an outcome that can tell us about the presence or absence of ischemia in a coronary vessel, not just the presence or absence of plaque or stenosis, but is that plaque and stenosis causing ischemia? And this is a study that looked at a machine learning model that used 37 plaque parameters that were generated from the deep learning model that we just talked about that looked at plaque quantification and stenosis severity. So it took 37 of those parameters and plugged them into a machine learning model. And the output was a binary, yes, presence of ischemia, or no, absence of ischemia. And this machine learning model, when compared to the gold standard, which is invasive, cath lab done invasive FFR, performed better than the computational fluid dynamic model for determining the presence or absence of ischemia. And it also predicted event-free survival in patients. There are also deep learning algorithms that are being developed for on-site use. This model currently is not an on-site use model. So what we use, our workflow currently is that every patient does not get these AI-based CTA evaluations. After the CTA is done, the reading cardiologist or radiologist determines if there is a need for the AI analysis, and then these images are uploaded onto a secure server. They are evaluated by the AI algorithm, and the report is sent back to the reading cardiologist or radiologist. And that physician then puts in the final report in the patient's chart, incorporating information that was obtained from these algorithms. So in conclusion, currently at this point in time, the greatest impact that AI is having in cardiac imaging is for segmentation and quantification to reduce the time spent in manual processing and to improve the adoption of quantitative measures, especially in echocardiography. But there are a lot of promising applications that are approved, and it remains to be seen how these will be used to change how we diagnose and how we evaluate patients for coronary artery disease and for a variety of different indications. So I am going to stop there because I only have a minute remaining. I'd be happy to take any questions.
Oh, that was perfect timing. Thank you so much, Dr. Samar. Yeah, well, if there are any questions, I'm going to pull up our Q&A box here. So we have a question from the audience. Are there any AI applications that you are aware of that use EKG as an input?
EKG is input for the imaging part of it, or just EKG for diagnosis? So EKG for disease diagnosis, yes. There are several. There are some that are available, and there are several in development looking at just EKGs and determining ejection fractions based on an EKG. So obviating the need to actually do an echo or a CMR or something. But I'm not aware of EKG being used as an input for an imaging-based algorithm.
Great, thank you. And one question that I've had is that, like you said, a lot of the AI and cardiac imaging applications that are available currently and, currently FDA cleared in the marketplace, a lot of them are related to segmentation and quantification. So, with so many of these applications kind of overlapping and doing the same, performing the same task, how do these tools differentiate themselves? What's the selling point for one application compared to another?
Yeah, in my experience, it's very difficult. They've all been studied. They all have sort of the approvals to back them up. The way I have done it is I have trialed each of them and seen what really works for me, what can really handle the variability. Yes, they can all give you the numbers at the end of the day, and they all need a little bit of tweaking of contours, which in the grand scheme of things is not so difficult to do. But what I have realized is that, how well do they handle variability of imaging really helps me decide what I'm going to use versus maybe not so much.
Excellent. All right. Well, I believe that's all the questions that we have. So we will conclude this third day of the AI literacy course. We will reconvene tomorrow at noon Central Standard Time, and we will be discussing AI in nuclear medicine, and we'll also be discussing algorithm bias. So look forward to seeing you all tomorrow. And thank you again, Dr. Samar and Dr. Talmor, for your time today. Really fantastic lectures.
Thank you.